Hey everyone, welcome back to Shock Doc Medical. I'm Dr. Raad, and today we're diving into a topic that's super important for anyone working in a hospital setting, or even if you're just curious about the hidden challenges our bodies face while we're in the hospital. I'm talking about hospital-acquired rashes. Now, have you ever wondered how a seemingly simple skin rash could actually be a sign of something much more serious, or even a clue to a dangerous systemic problem? Stick around, because we're going deep into the nitty-gritty of hospital dermatology. In today's episode, we're going to unpack everything from the challenges doctors face in diagnosing these rashes to a detailed look at the various types you might encounter. And trust me, whether you're a clinician or just a curious mind, you're going to walk away with some seriously useful insights. So grab your coffee, let's get into it. All right, so here's the deal. When patients are hospitalized, they're not just dealing with the illness that got them admitted. Many of them end up developing skin problems along the way. These can range from completely unrelated issues to signs of serious underlying systemic diseases, or even life-threatening skin disorders. And here's a kicker. Studies have shown that the dermatologic diagnoses made by non-specialists often match those of dermatology consultants in less than 50% of cases. That means there's a real risk of misdiagnosis, which could lead to improper, costly, or even harmful treatments, or sometimes no treatment at all. One study even found that only 31% of inpatient consults were deemed very relevant to the hospitalization or addressed a serious skin problem, while in 58% of cases, the consultation helped diagnose an important skin disease, even if it wasn't directly related to the reason for admission. This alone tells us that as healthcare providers, we need to be on top of our game when it comes to recognizing and managing these conditions. Now, why do so many skin problems occur in hospitals? Well, think about it. Hospitalized patients are exposed to a whole host of challenges. They're in an environment filled with potential irritants, from soaps and cleansers to disinfectants and adhesives on bandages. They're often immobile, which means pressure on the skin and nutritional impairments can exacerbate skin issues. Plus, the hospital setting itself exposes patients to various infectious agents, including some pretty nasty, sometimes antibiotic-resistant bugs. And let's not forget, many patients have compromised immunity from underlying illnesses or treatments like chemotherapy. In fact, one study estimated that about 36% of dermatological problems in hospitalized patients actually occur after admission. And when it comes to infections, factors like the loss of skin integrity from surgeries or IV lines can create those dangerous portals of entry for bacteria, fungi, and viruses. Now, diagnosing these rashes isn't always straightforward. The patient's previous skin history, current systemic illnesses, medications, both systemic and topical, are all pieces of a very complex puzzle. When a patient presents with a rash in the hospital, you've got to ask, is this a pre-existing condition that's flaring up because of the current illness or treatment? Or is it something new, a reaction to a drug, an infection from an IV line, or even an allergic response to one of the many products used in the hospital? Key signs that point to a serious condition include rapid changes in the skin, intense pain, severe itching, fever, blisters, mucosal lesions, or target lesions. It's these details that help steer us toward whether we're dealing with a relatively benign flare or something that might be a sign of acute skin failure. Let's break down the most common types of hospital-acquired skin problems you might encounter. I promise this is going to be detailed, but hang with me because it's all super important. Drug rash epidemiology and risk factors occurs in all ages and races. Higher risk in females, older patients, those on multiple medications, and immunosuppressed individuals, especially with drugs like sulfonamides, penicillins, cephalosporins, aromatic anticonvulsants, and allopurinol. History typically begins 4 to 14 days after starting a new drug, with variable itching. Serious reactions like DRESS, drug reaction with eosinophilia and systemic symptoms, and SJS-10, Stevens-Johnson syndrome, toxic epidermal necrolysis, come with high fevers, skin tenderness, severe edema, extensive purpura, target lesions, and mucosal involvement. Appearance often presents as a morbilliform rash, pink, red, or dull red macules and papules that tend to converge, especially on the trunk and extremities. Investigations. Skin biopsies usually don't help much. CBC can help differentiate from a viral syndrome, and more serious reactions might show abnormal liver function tests and chemistry profiles. Urticaria, hives, epidemiology, affects all ages and races in both sexes. History typically appears suddenly with transient, pruritic, edematous wheals. Sometimes there's also angioedema, especially around the mouth. Exam, you might see red or pink wheals of varying sizes scattered across the body, usually disappearing within 24 hours. Investigations. Mild eosinophilia is common, but if the urticaria is due to a systemic disease, you might see cytopenias, pronounced eosinophilia, or even signs of renal or liver issues. Contact dermatitis epidemiology, again, seen in all ages and races. Types and causes. Allergic contact dermatitis, often from exposure to metals, adhesives, fragrances, preservatives, formaldehyde, or topical antibiotics. Irritant contact dermatitis, more common in hospitals due to exposure to strong soaps, disinfectants, surgical preparations, bedclothes, and paper products. History and exam. Irritant CD tends to show up immediately with burning or pain if the irritant is strong, and more subacute, eczematous scaling with weaker irritants. Allergic CD usually appears 1-2 days after exposure and is pruritic, sometimes developing vesicles or bullae in severe cases. Investigations. Typically, you don't need a skin biopsy. Later, patch tests can be useful if an allergy is suspected. Seborrheic dermatitis epidemiology, common across all ages, but particularly in infants and postpubertal adults, as well as in patients with neurological diseases, chronic steroid use, or HIV. History and exam. Look for acute exacerbations of chronic dermatitis with variable itching that often worsens when regular bathing is compromised. It usually presents as greasy, loose scales on a pink base in typical seborrheic areas like the scalp, face, ears, intertriginous zones, chest, and upper back. Atopic dermatitis epidemiology affects everyone, often seen in individuals with an atopic background or family history of atopy. History and exam. It's a chronic, pruritic, eczematous dermatitis that can flare up. In infants, it might affect the extensor surfaces and face, while in older children and adults, it usually involves the flexural areas and can be widespread. Lesions are poorly defined, pink plaques with lichenification and excoriations. Investigations. Sometimes you might see elevated IgE levels and eosinophilia. Viral exanthem epidemiology, more common in children, affecting all ages and both sexes. History and exam. These rashes start abruptly and worsen gradually, often accompanied by fever, cough, sore throat, myalgias, headache, lymphadenopathy, conjunctivitis, and even gastrointestinal symptoms. They can appear maculopapular, morbilliform, urticarial, or even vesicular, and may involve mucosal surfaces. Investigations. Always consider a broad differential, including HIV, EBV, CMV, various herpes viruses, rubella, rubeola, enteroviruses, adenoviruses, parvovirus B19, and varicella. Lab work may include CBC, liver function tests, and specific viral antibody tests, along with swabs and washings from various sites. Herpes simplex, HSV, and herpes zoster, VZV, epidemiology, occur in all ages and races. VZV is more common in those over 50, and both can be particularly severe in immunosuppressed patients. History and exam. Patients often report tingling, pain, or burning before the rash appears. HSV tends to recur in the same spot, whereas VZV follows a dermatomal pattern and can disseminate. Investigations. Diagnostic tests included Zank smear, direct fluorescent antibody testing, PCR, and viral cultures. Cellulitis, epidemiology, seen across all demographics, especially in the setting of trauma, broken skin, or other portals of entry. History and exam. Presents with an abrupt onset of tenderness, pain, chills, malaise, and fever. The affected area is typically red, warm, and edematous with either ill-defined or sharply demarcated borders, usually unilateral. Investigations. CBC might reveal leukocytosis with a left shift. Cultures from any clear portal of entry are useful, and in unresponsive or immunosuppressed patients, a biopsy for tissue cultures might be necessary. Pyoderma, abscesses. Epidemiology occurs in all ages, often associated with trauma or other breaches in the skin. History and exam. Look for an acute or subacute onset of tender or itchy areas that evolve into weeping, eroded, crusted, and purulent lesions with surrounding erythema. Abscesses are characterized by tender, fluctuant red nodules. Investigations. Incision and drainage followed by skin culture is typically the way to go. Candidiasis epidemiology affects all ages and races, with risk factors including broad-spectrum antibiotic use, diabetes, hyperhidrosis, occlusion, and corticosteroid use. History and exam. Patients might experience pruritus, tenderness, and burning, with bright red, moist, or erosive dermatitis that is poorly marginated and may have satellite pustules, especially in intertriginous areas or the genital region. Mucosal surfaces might show white, removable exudates. Investigations. A KO8 prep showing budding yeast and pseudohyphae is diagnostic, and cultures are recommended if the condition is unresponsive to initial treatment. Fungal infections, tinea. Epidemiology, seen in all races and both sexes. Tinea capitis is more common in prepubertal children, while other forms, such as tinea cruris and tinea pedis, are often seen post-puberty, with males being more commonly affected. History and exam. These infections can be more severe in immunosuppressed patients and are linked to factors like obesity and hyperhidrosis. They generally present as dry, scaling, annular lesions with central clearing and an active border, sometimes with a moccasin pattern on the feet or interdigital involvement. Nails may show a powdery scale with subungual debris. Investigations. KOH prep showing branching hyphal structures, pus stain, and fungal cultures help nail down the diagnosis. Vasculitis, epidemiology, affects all ages and races, but is more common in adults with underlying rheumatologic, hematologic, or infectious diseases, or after exposure to certain drugs. History and exam. Patients typically present with painful or burning lesions that may range from non-blanching palpable purpura on the lower extremities to purpuric nodules and even ulcers that correspond to the size of the involved vessel. Investigations. Biopsy of the affected area can provide definitive clues regarding the type of vessel involved and the nature of the inflammatory process. Erythroderma epidemiology, most common in adults, with idiopathic cases frequently seen in adult males, although it can affect all ages and races. It may be caused by severe underlying dermatitis, Sézary syndrome, drug reactions, or pityriasis rubra pilaris. History and exam. This condition is characterized by an acute or subacute onset over days or weeks, often in patients with a pre-existing milder skin condition. The entire body, over 90% of the skin surface, can become covered with extensive pink inflamed plaques or dull erythema, sometimes reflecting the underlying disease pattern. Investigations. Biopsy can sometimes be diagnostic, but in evolving cases, it might not be. Chronic cases raise concerns about hypoalbuminemia, anemia, and electrolyte disturbances, so CBC and flow cytometry to rule out cutaneous T-cell lymphoma might be necessary. Dress syndrome, drug reaction with eosinophilia and systemic symptoms. Epidemiology occurs in all ages and races, but is more common in women and adults, especially in immunosuppressed individuals or those taking certain drugs like sulfonamides, penicillins, aromatic anticonvulsants, and allopurinol. History and exam. Patients present with a variable exanthem along with fever and signs of organ dysfunction. The rash can be morbilliform, minimal, or in some cases include purpura, target lesions, and blisters. Facial and extremity edema, along with lymphadenopathy, is common. Investigations. Look for eosinophilia and signs of dysfunction in organs such as the kidney, liver, lung, or gastrointestinal tract. Immediate screening for organ involvement is critical due to the high mortality risk if not promptly recognized. Pyoderma gangrenosum, epidemiology, seen in all ages and races, though it is more common in adults and in patients with underlying diseases like inflammatory bowel disease, hematologic disorders, or rheumatologic conditions. It's also associated with recent surgery or trauma to the affected site. History and exam. This condition is marked by the rapid evolution of a painful, necrotic, or purulent ulcer that can expand quickly. It often starts as a very painful pustule and may be accompanied by fever. The classic appearance is a deep, purulent ulcer with an undermined, dusky border, commonly on the lower legs, but it can also appear on the abdomen, peristomal areas, or sites of recent surgery. Investigations. Although a biopsy can confirm the diagnosis, it is not always diagnostic on its own, so clinicians must also consider infections, vasculitis, and trauma in their differential. Wow, what a lot to take in, right? But here's the key takeaway. Hospital-acquired rashes are not just minor annoyances. They can be a sign of everything from drug reactions to severe infections or systemic diseases. And because the hospital environment itself predisposes patients to these issues, from compromised skin integrity to exposure to multiple allergens and irritants, it's absolutely crucial for clinicians to be meticulous in their evaluation. When assessing a hospitalized patient with a rash, Always take a thorough history. Ask about pre-existing skin conditions, recent medications, both prescribed and over-the-counter, and any topical products used. And remember, if you see signs like rapid skin changes, fever, pain, or mucosal involvement, it's a red flag that you might be dealing with something serious like SJS-10, DRESS syndrome, or even a severe infection. Now, I know I mentioned treatments in some of these conditions, but it's important to note that the article we're discussing today doesn't actually lay out specific treatment protocols or medication doses. It's all about diagnosis and understanding the spectrum of skin conditions seen in the hospital. So, while I can't give you a specific medication or dose for, say, treating a drug rash, I can stress that correct diagnosis is key to ensuring patients receive the proper care, whether that means adjusting a drug regimen or initiating targeted therapy after a thorough workup. All right, folks, that's a wrap on today's deep dive into hospital-acquired rashes. I hope this detailed rundown helps you, whether you're a healthcare provider or just a curious listener, better understand the complexity of skin issues in the hospital. Remember, accurate diagnosis is the foundation for effective treatment. And being aware of these conditions can help prevent misdiagnoses that lead to unnecessary, costly, or even harmful treatments. If you've got questions, thoughts, or even your own experiences to share, drop them in the comments below. Let's build a community of curious minds who are passionate about advancing medical knowledge and patient care. And if you enjoyed this episode, be sure to hit that like button, subscribe to ShockDoc Medical, and share this podcast with colleagues and friends alike. Next week, we'll be tackling another groundbreaking topic in medicine that might just change the way you think about patient care. So stay tuned. This is Dr. Raad, signing off. Stay informed, stay curious, and keep pushing the boundaries of what we know about medicine. Until next time, take care.